Mr. Chairman, colleagues, more than 20 years ago, a publication in the New England Journal of Medicine recommended to follow this algorithm for the treatment of obese patients. Over the years, much progress has been made, but even today, the algorithm is valid and starts from the assumption that the first and most important aspect in the management of obese patients is the motivation of the patient himself. When the motivation is ascertained, the suggested strategy is based on three strands, which are lifestyle changes with diet and physical activity, the pharmacological approach, and the surgical approach. We will now briefly review these three aspects. The first step is based on a dietary regimen with a reduction in energy intake of 500–1000 kilocalories days. Physical activity with at least 150 minutes of moderate aerobic exercises associated with 1 to 3 sessions of resistant exercises, and it is recommended a cognitive behavioral support. Note that 80% of people who lose weight with a diet alone regain their initial weight after a year or also increases it more. And of the remaining 20%, 90% after 2 years regain their weight entirely. And nowadays, well-sponsored dietary regimen is the intermittent fasting, which is an eating pattern during which you abstain from taking food for a period of time, which usually lasts between 12 to 16 hours. It is so fashionable and sponsored by very important people that last year it deserved an article in the New England itself, which however highlighted that the addition of intermittent fasting to a controlled diet over a period of 1 year doesn't determine differences in the extent of weight loss compared to the diet only. Here you can see that if the dietary regimen is associated with an increase in physical activity, results in terms of weight loss are amplified compared to the diet alone. This study refers to 52 weeks of intervention. When diet, physical activity, and lifestyle changes are not enough, the pharmacological therapy is recommended. And it is recommended in patients with a body mass index greater than 30 or body mass index greater than 27 with comorbidities, always in addition to lifestyle modification. The further intervention is based on bariatric surgery that should be considered if other weight loss attempts fail, but it requires lifelong medical monitoring. And finally, it is also important to pay attention to the prevention and treatment comorbidity. As regards the pharmacological approaches, the very first compounds used belonged to the group of noradrenergic and serotoninergic agents, but they had important side effects. Noradrenergic agents were associated with valvular diseases and hemorrhagic stroke in women, while with serotoninergic agents, upon suspension after 6 months, recovery of all the lost kilograms was observed. The other mixed noradrenergic serotoninergic agents, sibutramine, used at the dose of 5 to 15 milligram days, is associated with a rise in blood pressure. And while the lipase inhibitor orlistat is associated with a 90% weight loss, but is often discontinued for significant side effects. Sibutramine is a centrally acting serotonin and norepinephrine reuptake inhibitor drug used in the treatment of obesity. Chemically, it is related to amphetamine. The sibutramine undergoes extensive hepatic first-pass metabolism and is converted by demethylation into two pharmacologically active metabolites, M1 and M2. These two metabolites shows in vitro inhibitory activity of norepinephrine and serotonin reuptake approximately 3 to 5 times greater than that shown towards dopamine. Reuptake inhibition increases central concentrations of serotonin and norepinephrine, and to a lesser extent, dopamine. Sibutramine acts both on satiety with the neurotransmitter serotonin and by increases thermogenesis with the neurotransmitted norepinephrine. These effects takes place by attenuating the reduction in resting metabolism that occurs physiologically during weight loss. The calorigenic effect of sibutramine is attributable to a stimulation of beta-3 activity of brown adipose tissue, which, however, in humans, represents a very small percentage of adipose tissue. Sibutramine therefore acts on two basic goals of the therapeutic approach to the treatment of obesity, and namely caloric intake, food intake, and energy expenditure, the thermogenesis. What about orlistat? Orlistat is a potent, specific, long-acting inhibitor of gastrointestinal lipases. It exerts its therapeutic activity in the lumen of the stomach and the small intestine by forming a covalent bond with the serine active sites of gastric and pancreatic lipases. The inactivated enzyme is therefore unavailable to hydrolyze to absorbable free fatty acids and monoglycerides, dietary intake fats, in the form of triglycerides. So, with this important side effect of sibutramine and orlistat, fortunately now we have a new family of drugs. And to understand the new drugs used for weight loss, we have to remember the action of GLP-1, the glucagon-like peptide 1. This GLP-1 is an hormone produced by the bowel that stimulates insulin secretion and inhibits glucagon secretion by the pancreas. Its release occurs after the meal, therefore coming into action only when blood sugar rises due to the carbohydrates introduced with food. GLP-1 slows gastric emptying, increasing the sense of repletion in response to food intake, and reduces hunger, acting directly on the hunger regulation centers of the central nervous system. They also appear to have other potentially beneficial actions, including protection of pancreatic beta cells and protection of the heart. And after its release, GLP-1 is rapidly degraded by a specific enzyme, DPP4, the dipeptyl peptidase 4, but therefore its use for therapeutic purposes is not practicable except with a continuous infusion. And so, to overcome the problem of the rapid degradation of GLP-1, analogies have been developed, more correctly defined as GLP-1 receptor agonist, with a structure more or less similar to GLP-1, but which resist the degradation action exerted by DPP4, and which are sometimes linked to molecules that slow down their subcutaneous absorption. The two main incretin endogenous incretins are glucagon-1-like peptide and gastric inhibitory peptide. Both increase insulin secretion, but only GLP-1 suppresses glucagon secretion. On the basis of this evidence, molecules capable of acting as GLP-1 receptor agonists have been synthesized, and in particular, liraglutide for subcutaneous use and semaglutide used both subcutaneous or per-os. Now I will show you the results of studies performed with these two drugs. In this randomized head-to-head placebo-controlled trial, adults with obesity who didn't have diabetes were enrolled. After an 8 weeks low-calorie diet, participants were randomly assigned for 1 year to one of the first strategies: moderate to vigorous intensive exercise program plus placebo exercise group, treatment with liraglutide 3 mg day plus usual activity liraglutide group, exercise program plus liraglutide therapy combination group, or placebo plus usual activity placebo group. You can see that a strategy combining exercise and liraglutide therapy improved healthy weight loss maintenance more than either treatment alone. The benefits of liraglutide are not limited only to weight loss, but also to the metabolic and cardiovascular benefits associated with it. Note that the favorable effects on cardiorespiratory fitness, on glycated hemoglobin, on HOMA index, and in general health perception. Regarding semaglutide, this is a study published in New England on 2021. It shows that adults without diabetes who were overweight or obese had clinically relevant weight loss with weekly injection of semaglutide 2.4 milligrams added to lifestyle changes. This benefit is maintained during time observations of 68 weeks. This review underlined the favorable effects of semaglutide in reducing also blood pressure values in patients without diabetes. In obese patients with heart failure with preserved ejection fraction, treatment with semaglutide is associated with a significant reduction in symptoms and limitations to physical activity, improvement in physical exercise capacity, as well as weight loss. But look at this new compound, tirzepatide. Tirzepatide is a dual GLP-1 and GIP receptor agonist studied for the treatment of type 2 diabetes and obesity. The gastric inhibitory peptide GIP is an hormone produced by K cells of duodenum that slows down secretory activity and gastric motility and simulates insulin secretion. And tirzepatide works both as GLP-1 and GIP receptor agonist. The use of 3 different doses of once weekly subcutaneous tirzepatide, 5, 10, and 15 milligram, led to clinically meaningful and sustained weight reduction in obese adults without diabetes. And these results were published on a New England Journal in 2022. But results are now available also for a triple hormone receptor agonist, retatrutide. Retatrutide imitates the action of the GLP-1 hormone, so increases the feeling of satiety, reduces hunger, and slows gastric emptying, but it has two other mechanisms of action. It also acts as an agonist of the glucagon and GIP receptor. It is therefore a drug with a multiple mechanisms of action, hormonal triagonists. These are the results of a recent study published last year in New England. And you can see that in adults with obesity without diabetes, once weekly treatment with subcutaneous retatrutide led to sustained reduction in weight at 24 and 48 weeks. And the treatment with retatrutide was associated with improvement in cardiometabolic measures, including systolic and diastolic blood pressure, fasting glucose, and insulin and lipid values. But when diet, physical activity, and lifestyle changes and pharmacological treatments are not enough, there is the bariatric surgery option that is suggested for patients with BMI greater than 40 or BMI between 35 and 39.9 with comorbidities, or BMI between 30 and 35 with type 2 diabetes on individual basis. It should be considered if other weight loss attempts fail, and it requires lifelong medical monitoring. As you can see in this infogram, there are several different types of weight loss gastric surgery, including gastric bypass and gastric banding. These are data provided years ago by our research group. These results provide evidence that massive weight loss induced by sleeve gastrectomy triggers profound sympathoinhibitory effects associated with a stable and significant reduction in plasma leptin levels, whereas the improvement in insulin sensitivity was attenuated with time and unrelated to the sympathoinhibition. Bariatric surgery is accompanied not only by weight loss, but also by other different favorable effects. Here, in this review by Professor Cuspidi, you can see the reduction on left ventricular mass. Here again, you can see the effects of bariatric surgery on left ventricular function. And again, the effects of bariatric surgery on left atrial sides and relative wall thickness. Evidences have also been obtained on benefit of surgical weight loss and OSA with significant reduction of apnea-hypopnea index after surgery-induced weight loss. And finally, this meta-analysis shows that surgical-induced weight loss is accompanied with a reduction in type 2 risk development. And also this meta-analysis show that in the reduction of the development of arterial hypertension after surgical techniques. So we can therefore conclude that the suggestion proposed more than 20 years ago is still valid in its skeleton, with important innovation in pharmacological and surgical finds that make weight loss a possible objective. Thank you for your attention.